Hi everybody, welcome to Dr. Manny's YouTube Learnshops. Today, in this session, you will be reviewing evidence-based practice, but with selected models. Have a look and enjoy this slide, and hopefully it doesn't exist in clinical practice, which we all know it does. And remember that evidence-based practice obstacles include insufficient time, knowledge, skills of nurses, perceptions that evidence-based practice needs excessive time, something to do with the organisational culture and policies, as well as inadequate support from nurse leaders and managers. And this could include lack of resources and investment in evidence-based practice, which result in something that you're looking at right now. So our session objectives for this lecture or this presentation are to review the selected models of evidence-based practice, consider the salient points for each of the selected models that I've chosen to present for the evidence-based practice session, review benefits and detriments of evidence-based practice, and look at some of the barriers that could be encountered for the implementation of evidence-based practice. Remember, look, nurses and other healthcare professionals have developed numerous evidence-based practice models. And these models will continue to serve as guides that integrate the most current research to create best patient care practices. Evidence-based models help to assure complete implementation of evidence-based projects and to optimise the use of nurses' time and healthcare resources. But however, remember, there's no single evidence-based practice model that can meet all the needs for every nurse and every patient situation. Therefore, as I said, I'll review some of the most common evidence-based practice models used in nursing today, but for your purposes, if it's important to you, this requires further investigation. Let's just review the definitions again. So evidence-based practice, according to its originator with evidence-based medicine, it's the conscientious, explicit and judicious use of current best practice with clinical expertise and patient values and preferences in making decisions about the care of individual patients. Taken a step further by Sigma Theta Tau International, which is an honour society in nursing and one of the most prestigious organisations in the world, they state that evidence-based nursing practice is the process of shared decision-making between practitioner, patient and significant others based on research evidence, the patient experiences and preferences, clinical expertise and other robust sources of information. Okay, the models of evidence-based practice that we're going to review, these are selected models and frameworks, and primarily they've been selected so you can understand contextual factors that have an important role in practices which are evidence-based. And these are the most commonly described in the nursing literature. Okay, the 6 selected models that we're going to review are the Ottawa model, the Stetler model, the Iowa model, the A-STAR model, the Johns Hopkins nursing model, and the ARC model. Because they're the most commonly described in the nursing literature. Let's, however, remember the evidence-based practice model, the prototype. And remember that in 1996, it was Dr. David Sackett who defined evidence-based medicine, as I just indicated, as the conscientious, explicit and judicious use of current best evidence in making decisions about the care of individual patients. And it's the evidence-based practice model that's problem solving to all clinical decision making within healthcare organisations, and it's primarily to integrate the best available scientific evidence with the best available experiential, which means patient and practitioner, evidence. That was the foundation. Clinical judgment, relevant scientific best evidence, patient values and preferences, all formulate the triad for the evidence-based medicine, which is now the evidence-based practice triad. The first model that we're going to review is called the Ottawa model. And it's basically about how to use research. And this model has been revised several times since its inception in 1996, the most recent being in 2004. And the Ottawa model is an interactive model that depicts research as a dynamic process of interconnected decisions being made and actions taken by stakeholders. The model stipulates three main steps: to assess the barriers and the supports, to monitor the interventions and the extent of how they're used, to evaluate outcomes. And these are all subsumed under three phases and are designated with 6 primary elements. And they all have to be considered when integrating research into clinical practice. So this is the Ottawa model as formulated in 1998, most recent, as I said, being 2004. And the components basically are to assess, to monitor, and to evaluate. And assessing the barriers and supports basically means evidence based on innovation has to be clearly identified what the innovation is and what the implementation will be. And potential adopters are to identify, you have to identify the adopters with characteristics that could influence the adoption of the innovation. The practice environment is to identify the leaders, formal and informal, who can inspire change and assess the environment for needed resources. So have a look. When you look at the evidence-based innovation, this is a developmental process and it's got innovation attributes. Potential adopters need to be aware, have attitudes, skill, knowledge, concerns, and be able to be aware of current practices. The practice environment are the patients, the culture, social, structural, economic, and any uncontrolled events. When we're monitoring, well, we're talking about the implementation of interventional strategies and to be able to select appropriate strategies to increase awareness of implementation and provide necessary education and training for conducting the implementation. It's the adoption of innovation to determine the extent of the adoption of its implementation. And we have to be aware, as it's indicated, any barriers, transference and follow-up. When we come to evaluate the outcomes, this is about the patient, the practitioner, and the organisational system. So the 6 key elements in the Ottawa model are evidence-based innovation, potential adopters, the practice environment, implementation of the interventions, adoption of the innovation, and outcomes resulting from the implementation of the outcome. So have a look. looking at it further, when we look at potential adopters, that's us, the nurses, and we have to be aware, have specific attitudes, knowledge and skills, be confident and be able to implement current practice. The interventions could be education, coaching, workshops, performance feedback. The outcomes all involve the patient, the practitioner and the system. Patients, however, are central to the model's process and their health outcomes are primary. They're the primary focus. This model focuses on the unit level environment instead of the whole of the organisation. And it's the prescriptive aim of the model, as I said, to assess, monitor and evaluate. So what are the points to consider? Remember, patients are central to this model's process and their health outcomes are the primary focus. The model focuses on the unit level environment instead of the entire healthcare organisation. The prescriptive aim of the model is to assess, monitor and evaluate. Now let's look at the second model. And this is the Stetler model, which refers to evidence-based practice within the model. The objectives of the model are a quality improvement tool, create formal change within the organisation, promote critical thinking and reflection in research. And it's the Stetler model that enables practitioners to assess how research findings and other pertinent evidence are implemented into clinical practice. The model examines how to use evidence to create change that fosters a patient-centred, focused care. And as I said, it's designed to encourage critical thinking about the integration of research findings, promote use of best evidence as an ongoing practice, help lessen errors in critical decision-making activities, and allow the categorisation of evidence as external, which is research, or internal, which is organisational outcome data. However, it emphasises the use by a single practitioner, which could include groups of practitioners or other stakeholders. And it's similar to the nursing process in that it has 5 phases: preparation, validation, comparative evaluation and decision making, translation and application, and evaluation. So when we look at phase 1 of the Stetler model, this is preparation. And this defines the need for clarity of purpose and significance, to identify the priority that it's needed, and to recognise the purpose of the evidence-based practice project, to distinguish the context in which the project will occur and pinpoint relevant sources of evidence. Phase 2 deals with validation, and this assesses sources of evidence for levels and overall quality, and it determines whether the source has got any merit or goodness of fit, and whether to accept or reject the evidence in relation to the project purpose. It determines credibility of the findings. It reflects relationships or variables pragmatically, and there's a real focus on critiquing the evidence. And therefore, it identifies study details and qualifiers. In phase 3, the comparative evaluation and decision-making phase, this is where evidence findings are logically summarised and similarities and differences among the sources of the evidence are evaluated for fit of setting, feasibility, current practice, substantiating evidence, and this is to determine whether it's acceptable or feasible to apply the findings to practice. Basically, you're deciding whether to use it or not use it? Is it good quality research or is it poor quality? In phase 4, which is referred to as translation and application, this describes how to implement the findings and recommendations to develop the how-to for implementation of summarised findings. Identify practice implications that justify findings for change. And therefore, in this phase, you decide to accept with or without modification, or reject and stop. In phase 5, this is where you appraise dynamically. You identify a goal for each, you obtain evidence regarding changes in outcomes, and you use iterative back and forth evidence to achieve goals, and evaluation is part of a routine practice. So points to consider with the Stetler model are that it encourages critical thinking about the integration of research findings. It promotes the use of best evidence as an ongoing practice. It reduces errors in critical decision making, and it allows for the categorization of evidence as external, that being research, or internal organisational outcomes. It emphasises the use of single practitioner, but again may be extended to groups of practitioners and other stakeholders. The third model that we're going to review is the Academic Centre for Evidence-Based Practice, ACE. It's the STAR model of knowledge transformation. And as a framework, the model systematically integrates best evidence into practice. The model's got 5 major points or stages that depict forms of sequential knowledge transformation. And these are discovery, which is the stage that involves searching for new knowledge, which is found in traditional quantitative or qualitative methodologies. You've got evidence summary, and the primary task here is to synthesize the body of research knowledge into a meaningful statement of evidence for a given topic. And this is a knowledge generating stage which occurs simultaneously with new findings that may arise from the synthesis. Then you've got translation to guidelines. And the aim of translation to guidelines is to provide you as a clinician with a practice document, for example, clinical practice guidelines, derived from the synthesis and summation of the research findings. Then you've got practice integration. And this is where the practitioner and the healthcare organisation practices are changed through formal and informal channels. The final one is the process and outcome evaluation. And this is an array of evidence-based practice outcomes that are evaluated on impact, quality and satisfaction. So during this model's phases, research moves through cycles to combine with other forms of knowledge before integrating it into clinical practice. So the A-STAR model focuses on discovery research, evidence summary, translation to guidelines, practice integration, a process and outcome evaluation. There are 8 principles involved in knowledge transformation in the ACE model. It's necessary prior to implementing research into practice. To review it, it's derived from multiple sources such as resource, experience, experts. The research process is the most stable source of knowledge in this model. Evidence reliability and validity is classified based on rigour. The research is converted via a systematic approach, and other knowledge is created as a consequence. Forms of knowledge can be referenced to its use, and the form of knowledge determines its usability. And it uses all the 5 steps in the ACE model. Looking at another way, the 8 principles are here. 1, necessity, or it's necessary prior to implementing the research into practice. It's derived from multiple sources, research, experience, and experts. Research process is the most stable source of knowledge, and evidence must be reliable and valid. And this is to do with quality, rigour. Research is converted via a systematic approach. Other knowledge is therefore created, and forms of knowledge can be referenced to its use. The form of knowledge determines its usability, and it uses the ACE 5 steps. So points to consider in the A-STAR model are: focus on promoting the use of evidence-based practice for direct care nurses. It includes the use of qualitative evidence, and the primary goal of the model is knowledge transformation. However, interestingly enough, it doesn't incorporate non-research evidence, which means patient values and practitioners' experience, considering it advocates qualitative evidence. It identifies factors that impact adoption of innovation. The ARC model, or Advancing Research in Clinical Practice model, is the next one that we're going to review. And it's the ARC model that was first conceptualized by Melnick as a mentorship framework to assist advanced practice nurses in implementing evidence-based practice. And it integrates control and cognitive behavioural theories, which means quantitative and qualitative theories, and works to build a group of evidence-based practice mentors to advance evidence-based practice in any system. It's the application which is often within a research-intensive environment such as acute care. And this assesses healthcare organisations for the readiness for change and the implementation of an evidence-based practice project. It identifies potential and actual barriers to the facilitators of the project. It identifies evidence-based practice champions or mentors to work with direct care nurses or specific clinical units, and it implements evidence into practice. It evaluates evidence-based practice outcomes. So, the central model constructs are: it assesses healthcare organisations, the culture for change and readiness, and implementation or implantation of the evidence-based practice. It identifies potential and actual barriers to facilitators of that practice. It identifies mentors or champions to work with direct care nurses, and it implements evidence into practice and then evaluates the outcomes. The ARC model promotes the use of evidence-based practice amongst advanced practice nurses and direct care nurses. It identifies a network of stakeholders who are supportive to the project, and it includes cognitive behavioural theory underpinnings. The emphasis is on healthcare organisational readiness and identifies facilities and barriers, and it encompasses research, patient values, and clinical expertise as evidence. So the points to consider are: it promotes the use of evidence-based practice amongst advanced practice nurses and direct care nurses. It identifies a network of stakeholders who support the evidence-based practice project. It has underpinnings which are behavioural. And there's an emphasis on healthcare organisations to be ready and identify facilities and barriers. And it encompasses research which includes patient values, clinical expertise as evidence. Now, the Johns Hopkins nursing evidence-based practice model, this is a model that applies problem solving as an approach to clinical decision making. And it's designed to meet evidence-based practice needs for direct care nurses. And it utilises a very uncomplicated three-step process referred to as PET. A practice question, evidence and translation. And it combines the nursing process, American Nursing Association standards of practice, critical thinking and research utilisation, and as such is developed to accelerate research into nursing practice, autonomy and leadership. The essential steps in the PET process is the practice question, and this uses a team approach, and the evidence-based practice question is identified. The evidence is the team searching, appraising, rating the strength of the evidence, describing the quality of the evidence, and making a practice recommendation on the strength, which again is the reliability and validity and trustworthiness of the evidence. The translation, in this stage, it's the feasibility which is determined and an action plan is created and a change is implemented and evaluated, and the findings are presented to other healthcare organisational members and the broader nursing community. The model begins with an evidence-based practice question, which is PICO, which we've discussed. P is the patient population problem, I, the intervention, C, the comparison, O, the outcome desired, and there are other steps which involve literature search, team appraisal, recommendations, and a translation phase. What are the points to consider? Well, the Johns Hopkins nursing model emphasises individual use of a well-developed toolkit that provide nurses with a guide for question development, with evidence rating scales, and with an appraisal guide for various forms of evidence. Now, the Iowa model of evidence-based practice is the last model that we're going to look at, and this one focuses on healthcare system, which includes the patient, practitioner and the infrastructure, and to implement and guide practice decisions based on the best available research and evidence, which the concept is now no longer new to you. Evidence-based practice is based on the best available research and evidence. The essential steps are to identify either a problem-focused trigger or knowledge-focused trigger, and that'll generate the need for a practice change. To determine whether the trigger is a healthcare organisational priority. Do we want change? Reflect on the team's topic of interest and include interested stakeholders. The team then searches, appraises, synthesises the literature related to the topic. Then, evaluation of the availability and merit. And this is the level of evidence, the quality of evidence, which we've looked at. And if the evidence availability has merit or is lacking in merit, then this is identified here. If credible and reliable evidence is available, then a pilot study is performed and the practice could change. Then appraise the pilot for the level of success. If the pilot was successful, disseminate the findings within the organisation and implement recommended changes into practice. So the Iowa model focuses on triggers, problem-focused triggers. This could deal with risk management, process data improvement, identification of a clinical problem, or internal and external benchmarking. Knowledge-focused triggers are to do with new research or literature, standards or guidelines, philosophies of care. It focuses on whether the topic is an organisational priority. If it's not a priority, consider other triggers. If it is a priority, form a team, assemble relevant research, critique and synthesise the research for clinical practice. Is there a significant research base? If there's not, conduct research. Base the practice on lower levels of evidence if the higher levels aren't available. If yes, if there is a significant research base, then you can do the pilot to practice the change. Collect baseline data, design evidence-based practice guidelines, implement the evidence-based practice on the pilot wards, and evaluate the outcomes and then modify. Is change appropriate to adapt to practice? If no, continue to evaluate quality of care and knowledge. If yes, institute a change in practice, monitor and analyse the process related to the outcome data, and disseminate the findings. What are the points to consider? Well, the points to consider with the IL model are: recommend for use at an organisational systems level. This uses pragmatic problem-solving approach. It uses detailed flow charts in decision-making process. It clearly identifies decision points and provides feedback loops in the model. It emphasises the necessity for pilot projects before initiating a big system-wide project. And it's designed not just for nurses, but for interprofessional collaboration. So what are the benefits of evidence-based practice? It provides better information to the practitioner. It enables consistency of care. There are better patient outcomes, and it provides client-focused or patient-focused care. It's a structured process. It increases confidence in decision-making. It generalises information and contributes to the science of nursing. It provides guidelines for further research and helps nurses to provide high-quality patient care. What are the detriments? Typically, often there's not enough evidence for evidence-based practice. Some practitioners consider it time-consuming. There's a reduced patient choice, reduced professional judgment and autonomy. It suppresses creativity. It influences legal proceedings and may influence publication bias. What are the barriers? Well, there's a lack of value for the research in practice, difficulty in bringing change, lack of administration support, lack of knowledge of nurses, whether they're mentors or practitioners. There's a lack of time for research, which there is. There's a lack of knowledge about research, and research reports are not easily available. There's complexity in the research reports terminology, and there's a lack of knowledge about what evidence-based practice actually is. So in summary, evidence-based practice has become a key principle for the provision of safe, effective, quality nursing care. In nursing, it's therefore critical that evidence-based practice exceed the expectations of conventional research and be based on evidence which is trustworthy, reliable, and valid. There's an increased awareness that continues to grow in regard to the concept of evidence-based practice because it's got a critical role in theory development and is required for excellence for nursing practitioners and nursing practice. So in conclusion, evidence-based practice nursing care is a lifelong approach to clinical decision making and excellence in practice. Evidence-based nursing care is informed by research, findings, clinical expertise, and patient values and preferences, all of which can improve patient care outcomes. Employing trustworthy evidence in clinical practice, currently in the year 2020 now, it's now expected standard of practice for all nurses and healthcare organisations. But, as I indicated, there are many barriers that still remain, and I've only touched on some of them. and this creates a gap between new knowledge and the implementation of that knowledge for patient care. And using levels of evidence, however, nurses can determine the strength of research studies, assess findings, and evaluate the evidence for the implementation into best practice. Thanks everybody. Check out any of the other Dr. Manny Learnshops on YouTube if you thought this was of any benefit to you. Bye for now.